This is an important talk because we have some evidence about neuroplasticity. So the wonderful thing is now we have hardcore research that shows that patients with MS have cortical reorganization. We can stimulate areas of the brain that were like dormant, sleeping, and we can get these other neurons to take over the job for neurons and axons that have been demyelinated. Patients with MS have unique needs. So it's chronic progressive nature, unpredictability of symptoms. We don't see that fatigue. Sometimes we don't hear about the fatigue, but it impacts them, again, physically, but also psychologically, mental-wise, that fatigue impacts them. They have dysesthesias, paresthesias. They could have bladder, bowel problems, depression, mood issues, heat sensitivity. And again, that underlying psychological component, oh my God, I've been diagnosed with multiple sclerosis and I'm going to get worse and I'll be in a wheelchair within 10 years. So they have that going in their head as well. So are there opportunities to promote cortical reorganization in MS after an exacerbation? And the great news is the capacity of the central nervous system to adapt to new environmental challenges or anatomical damage contributes to the functional recovery after brain injury and occurs in MS. There is cortical reorganization in MS. So a retrospective analysis of 10 patients who had clinically isolated syndrome, so that's typically the diagnosis before you get MS. Oh, you had a clinically isolated syndrome. When you've had your second exacerbation, then they say, oh, it looks like you got MS. The MRI findings indicative of MS, they present with hemiparesis at the onset of symptoms, no further clinical episode. Mean age was 32, give or take 9 years. Disease duration was 24 months, give or take 14 months. Median EDSS was 1.25, so very, very low, very high functioning people. 10 age-matched healthy controls. They looked at 2 functional MRI trials, 1 per hand, just doing the simple finger to thumb tapping. That's all they were doing. Movements of the affected and unaffected hand activated significantly larger areas in patients than in controls in both the contralateral and ipsilateral cortical hemispheres. So these were people with a very mild attack of clinically isolated syndrome, some demyelination of axons that had some minor impairment of their hand. And when they looked at them on functional MRIs, they were showing in these folks with this attack that they were already having other neurons becoming activated in order to stay successful with that finger to thumb tapping. Movements of the affected and unaffected hand activated significantly larger areas and in the ipsilateral. So if I'm moving my left hand, then my right cortex is being activated, right? What they're seeing is that the left cortex is also being activated now to have success in moving my left hand. So the brain on its own is reorganizing to maintain independence. So I put this up quickly to remind you neuroanatomically, when we have those cortical spinal tracts come down, that synapse on the alpha motor neurons, typically it's the lateral cortical spinal tract on my right side that's going to descend, cross over at the pyramidal decussation, control the left side of my body. The medial cortical spinal tract, or sometimes called ventral, stays ipsilateral, descends down, and synapses on my alpha motor neurons. So what they're saying is now this medial or ventral cortical spinal tract is becoming even more active in order to maintain function. It's not all that lateral cortical spinal tract being activated, it's the ipsilateral hemisphere giving rise to action potentials coming down an existing tract that's not impacted. So here's a nice functional MRI. A, C, and E are the healthy controls, and they're again just doing a finger manipulation, just finger walking like that. They're in a functional fMRI machine. A, C, and E are the healthy controls. Little bit of activation, see the red and yellow? That's the neurons that are being activated to do that task. BDNF. These are the patients that had a lesion suggestive of MS, moving their clinically unimpaired hand, and look at the change in neurons activated to ensure success in doing that particular task, in moving the clinically unimpaired hand. So the brain on its own, in response to some type of inflammation, is starting to reorganize in order to maintain success in all the tasks that we need to do. Here's another one. Healthy subjects are at the top, A, B, and C. Again, the patient is in an fMRI. They're, again, moving finger activation. The patient has changes in activation in different areas of the brain. So E is the new area that's showing up here in the patients that have lesions. And then size of activation is changing in the other areas. So again, on its own, the brain is reorganizing and reactivating and firing neurons that are otherwise not active, but in order to maintain success in completing the task. So fMRI during a simple motor task in 12 patients after a pseudotumoral lesion. Pseudotumoral lesion just means it could be an angioma, it could be a benign cyst, it could be the first evidence of MS, an MS lesion. So that's a pseudotumoral lesion. In 15 matched controls, results primary sensory motor cortex of the, there it is again, ipsilateral. So the hemisphere that would give rise to that medial cortical spinal tract is becoming activated because of a potential problem on the dominant hemisphere that would control that side. Everybody follow what I'm talking about there? So sensory motor cortex of the ipsilateral hemisphere was significantly more active during task performance with the impaired than unimpaired hand, even with the impaired versus unimpaired hand. During task performance with the unimpaired hand, the ipsilateral cerebellum and several motor areas in the opposite hemisphere were significantly more active. So on its own, without any provocation, without any wonderful OT or PT, the brain is trying to continually respond to any type of damage or inflammation in order to maintain functional activity. A recovery of function of the primary somatosensory cortex of the affected hemisphere was found in 4 patients with clinical improvement. In the 2 patients without clinical recovery, there was persistent recruitment of the primary sensory motor cortex of the unaffected hemisphere. Conclusions: pseudotumoral MS lesions affecting the motor system can determine short-term cortical changes characterized by the recruitment of pathways in the unaffected hemisphere. And this is all going on without provocation, without any type of stimulation. The brain on its own is responding to these lesions. So MS alterations are not confined to white matter lesions, we know that, but may be found in both normal appearing white matter and in gray matter. It's been established that irreversible tissue damage in MS leads to disability. It should, however, be borne in mind that the clinical outcome in people with MS is the result of a balance between the severity of damage to the central nervous system and the effectiveness of the repair and recovery mechanism in such patients. These plastic changes are believed to consist of an increase in the extent of activation in the affected brain areas, as well as the recruitment of additional brain areas, that being that ipsilateral hemisphere. So in MS, the bulk of evidence suggests that plasticity limits the clinical impact of damage by establishing patterns of brain activity different from those of healthy volunteers, and accompanies improvements in motor performance with practice by adaptively reorganizing those altered patterns. And in fact, they think that spontaneous recovery from an MS exacerbation, so somebody has an exacerbation and within 48 hours they're better. They think that's from this literal reorganization, if you will, or activation of the ipsilateral hemisphere to take care of the impairment that might be shown from the contralateral hemisphere. So the brain is constantly responding to these inflammatory attacks. And it's thought that we might have 10 billion neurons, and maybe we use 1 billion, if that. That means you got 9 billion neurons sitting there waiting to be activated that can become activated, again, without any type of stimulation in order to maintain function. Then, in addition to that, so the brain's power to reorganize on its own, to activate silent neurons in order to maintain function on its own, then we can bring in this whole new idea of BDNF. So BDNF is brain-derived neurotrophic growth factor, and that plays an important role in neuroplasticity and promotes axonal growth, but its secretion is regulated by a BDNF gene, which declines with age. So those of you over 40, the BDNF gene is not producing as much as it used to. Those of us over 60s, we're in more trouble. So BDNF and exercise. One of the most exciting areas of investigation of exercise in MS is the production of neurotrophins like BDNF and what's called nerve growth factor. Neurotrophins play an important role in neuronal repair and plasticity. And recent experimental evidence suggests the neuroprotective effects of these proteins in MS. So they're actually acting to protect neurons from being damaged. The BDNF is doing that. It looks like exercise can stimulate some of the production of BDNF. 30 minutes of moderate exercise significantly induced BDNF in people with MS as well as control subjects. The authors concluded that moderate exercise may be used to induce neurotrophin production in humans. So here's the study. 11 subjects with MS, 11 age-matched controls. They completed an 8-week exercise program 3 times per week, consisting of a 3-minute warm-up at self-assessed comfortable speed, followed by 30 minutes of psychoergometry at 60% of the VO2 peak. They measured their elevated resting serum BDNF, which was found following 4 weeks of exercise training with a return to baseline at week 8. So the exercise stimulated an increase in the secretion of BDNF. So BDNF is a healthy protein that helps synaptic activity, that helps neuronal processing. So the exercise induced more production and secretion of BDNF. Similar observations have been reported in healthy animal models. At the end of an 8-week training program, the BDNF in the subjects with MS was back to baseline. So it's short-lived. So if you were to do an exercise program with somebody with the intent of secreting more BDNF, in that same period of time when they're in that exercise program, you would want to really push motor control activities. So if they're having a lot of difficulty with hand function, so the occupational therapist is working with them and they're doing different types of exercises, functional retraining, cutting with a knife and fork, whatever, handwriting, keyboard operating, whatever the patient was having deficits in doing, they would push that repetitive practice of that motor task during this period of time when BDNF was being secreted at a greater level, and that enhanced more cortical reorganization and recovery of function. So the thought process is exercise plus motor control stimulation, task-specific training during that period of time when you're having more BDNF being secreted. No study could show a long-lasting BDNF response to acute exercise or training, so there's no permanent increased peripheral BDNF circulation in healthy subjects or persons with chronic disease. More BDNF could be released into the blood circulation, which may be absorbed by central and or peripheral tissues, where it could induce a cascade of more neurotrophic and neuroprotective effects. So it's another venue by which we can use exercise with patients, especially during the period of time where we're working on helping them recover from a recent exacerbation that's cause more inflammation and demyelination. So some specific factors to consider, obviously the individual. So they have MS-specific symptoms, so weakness, presence of abnormal movements, spasticity, even problems with short-term memory as well as fatigue. The task, so you may have to still start very simple and progress to complex movements. You wouldn't want to jump into a hard hand exercise immediately. Define the task so that the patient can perform and practice repetitively at home. So repetition is still very important. And then modify the environment that the patient is working in so that the brain has to continue to figure out how to move within that different environment. So let's say you were having the patient do some simple hand task such as picking up a water glass. So that might be an activity and placing it on 2 targets. Then you might modify that task by making it a shot glass. So now a smaller surface. Then you might modify it by making it a utensil. So they're picking up different objects. You keep putting different types of stimuli into the brain, so you're forcing the brain to have to respond to that stimuli and activate the neurons needed to be successful. So this one's pretty straightforward. That's a pretty lousy gait. So she looks predominantly like a right hemiplegic, excessive leaning to the left-hand side, severe hip hiking, swinging the leg out to the side, high risk for falls, right? Everybody would agree with that. So that's her ambulation. That's her learned motor behavior. The longer we let her move like that, that's ingrained in her brain as how she's going to walk. So repetition of abnormal movement becomes the learned motor program. The longer we let that persist, that's it. We're not going to change it. Can this abnormal movement pattern be changed? Is there anything we could do to change that? What would we do? Retrain. Okay, what might we be able to use to try and retrain that movement? Any ideas?
Maybe a different assistive device for a while.
Okay, maybe a different assistive device. So the arm looks like it's here, but if she can use the right arm, maybe we could give her a 2-wheeled rollating walker, and that would make her more symmetrical, and that'd get her away from that. So maybe a different device. Any other thoughts? Sorry? An ankle support. So try and pick that foot up a little bit more. Yep. Anything specific you're thinking of?
Even assessing what actually causes that gait. What is spasticity or weakness?
Right. Good point. So what's the underlying cause of that gait dysfunction? So it is weakness and spasticity. That's the biggest problem. No iliopsoas, no hamstring, no anterior tib. Spasticity throughout in the extensors. And the left leg is not fine, but the right leg is definitely more involved. Okay, so one thing we have available to us, even if it's not available to the patient, but we might have it in the clinic, is a functional electric stimulator. So Lacey showed a patient earlier this morning walking with, what did they, what? So we wanted to give equal time. So this morning, the individual was walking with the BDNF. This is the walk aid. So she's got a functional electric stimulator that's now helping her with hip flexion, dorsiflexion, so she doesn't need that excessive trunk leaning to swing that leg around, because now the leg is actually starting to move. Look at the change in her postural alignment. So even if she couldn't afford, or if the insurance wouldn't pay for a functional electric stimulator, if we repetitively do this in the clinic, we're stimulating more of that motor program we want to occur in the brain versus all of this going on. The longer that persists, that's it. But if we can create opportunities where we can get the muscles to activate the way they were intended to activate, we can change that program in the cortex. So these functional electric stimulators, I don't know how well it works in Canada getting them reimbursed. It's, yeah, kind of hit or miss in the States as well. But they can make such a huge difference, not only in how the patient walks, but decrease fall risk. Okay, we saw Jean earlier this morning. So remember she had that lousy sitting balance? And I would bet, how many people would have thought to stand her in the parallel bars based on what you saw with her transfer, right? She needs assist for lateral transfer. Why the heck would you think she has the ability to stand in the parallel bars? And yet, you don't know unless you try and give the patient the opportunity. She's standing without even a PT next to her. And she's watching that iceberg, and she's so engrossed in that visual processing and trying to control that penguin on the iceberg that she's got this wonderful ability to maintain static standing with weight shifting. So we want to include recreational activities as well. Here's Deal. Deal was diagnosed with MS when she was 52. She thought it was the end of the world. She's got 3 grandkids. How am I going to be able to play with my grandkids? I've got MS. I'm going to be in a walker. I'm going to be so disabled, yada, yada. She was more depressed than she was limited physically by her MS. She was an avid golfer. Her main problem was her left lower extremity. She had the weakness spasticity. She had a lousy gait. So half of the motivation for her was, we'll get you back out on the golf course. You know, but we got to do some work on that leg. And part of the work we're going to do on that leg is having you hit some golf balls in the clinic, because that's going to increase your weight shifting. That's going to increase your trunk rotation. That's going to activate your ankle strategies. You know, then we're going to have you walk on an uneven surface, because guess what? You got to walk the course. Can't ride everywhere. You know, you got to walk up a little bit of a hill to get to the green. So then you create environments where she's got to practice ambulation in different situations. So include recreational activities. Then we showed you Debbie just before we got off on this little tangent again. Remember you saw Debbie walking with a 2-wheeled walker? No, 4-wheeled walker. How many people think Debbie's still ambulatory? So that video was probably 6 years ago. How many people think Debbie's still ambulatory? All right, be optimistic. How many people think maybe she's on a 2-wheeled walker now because maybe the 4-wheeled was too trouble? Or you think she's still on the 4-wheeled walker? Still on the 4-wheeled walker? Okay. Yeah. Debbie now walks without an assistive device. Walks without an assistive device. Outside. She does have to hang on to the rail when she goes up and down the curb to come into the clinic, but she walks without an assistive device. She's not fast, but she's safe and she's independent. But she's been probably one of the hardest working individuals. How long? Maybe 8 years? Over time?
Yeah.
With Debbie coming in?
It's been since I've been there, so it's been a little while.
Yeah, and you know, she was diagnosed, of course, with progressive MS, so they hear that too, and you know, what's your headset right away? Oh, I'm going to be in a wheelchair. Debbie's wasn't that. Debbie's was, what do I need to do to get stronger? So she was in short-term rehab, then she came into the wellness program, then she came into post-rehab. She would be seen when she'd have a little blip, you know, and things would flare up, get right back into her exercise program. Was wearing an ankle-foot orthosis there. Now doesn't wear the ankle-foot orthosis. So we can do a lot to reorganize, to stimulate the brain, to help the muscles work more effectively, even though they might have lesions there that on MRI look like they shouldn't be functional. We shouldn't let the MRI dictate what we're doing from a rehabilitation perspective. We should take what the patient has and then put in place as much of an aggressive rehab program as possible to get them to their highest level of function. I have to say, Debbie's progress shocked both Lacey and I. I would never have said that she'd get to the point where she could ambulate without an assisted device, but she did. So summary, established lifelong relationship with the individual living with MS. We have the luxury of doing that because we have a private practice. So for the most part, you know, we run post-rehab. It's very economically feasible for patients. If they can't afford it, doesn't matter. We have students that come in, volunteer. It's a great learning opportunity for the students. But the more we can really put a lifelong relationship in with these individuals, promote active exercise for health and wellness, as well as opportunity for neural repair, cortical reorganization, Stimulate, stimulate, stimulate. Give them in different environments that they like to do, that they like to engage in, because if they like it, they're going to practice it even more. And then empower individuals to manage symptoms that impact on function. Oh, here's Michael. Michael was the guy we saw earlier. He was in Dr. Jacobs' study. So at this point, Michael's non-ambulatory, so he's got to use the wheelchair. But he pulls the wheelchair right over to the elliptical, because damn if he's going to stop exercising, right? So he gets himself on the elliptical, and he's going to get started. This is great exercise. Oh, he's got to set it, because he's very competitive. So he's got to make sure he goes at least 30 seconds or a minute more than he did the day before. But watch the smile on his face. Look at the great weight bearing. Look at the ankle activation on the elliptical. Getting great aerobic exercise, oxygen, glucose to the brain, and he's happy. So exercise is key for all of us, and especially for our folks with MS.